Sounds good. Well, great. So we are ready then to get started. So I will introduce our speaker, although I'm sure you have all attended at this point. We've had, I think, at least 3, maybe 4 webinars from Dr. Brewer. So you may have seen him before, but we realized when he joined the Zoom that this is the first time that we have seen him on camera. So we've done these on GoToTraining. So it's exciting to see Dr. Brewer in person and go through another webinar with him. So I will give a brief introduction and then I'll pass it over to him for the rest of the time. All right, so Dr. Tim Brewer is a professor in the Division of Infectious Diseases at the David Geffen School of Medicine at UCLA and a professor of epidemiology at the UCLA Fielding School of Public Health. He's an authority on using analytic methods to optimize the population-based control of infectious diseases. He has extensive experience developing and overseeing training, education, and service programs both locally and in countries around the world, and he has received multiple teaching awards for his efforts. Dr. Brewer has served on advisory boards and review panels for numerous international and national organizations, including the World Health Organization, the NIH, the CDC, and the Canadian Institutes of Health Research. He currently serves as chair on the board of the board of directors for the Consortium of Universities for Global Health. So far, Dr. Brewer has presented multiple webinars for our network in the past on COVID-19, and these webinars have all discussed the science behind the pandemic and strategies for controlling its spread. Today, he will expand on these webinars by discussing the Omicron variant and then the efficacy of the COVID-19 vaccine. So please join me in welcoming Dr. Timothy Brewer as he presents this webinar, which is an extension on his Preventing Pandemics in an Interconnected World series, and this one specifically about the Omicron variant. So welcome, Dr. Brewer. Thank you so much for joining us today.
Well, thank you very much, Martha, for having me, for the kind introduction. I'm really delighted to be here. And we can do this informally. I'll kind of run through the slides, but if you have questions, we can either jump in or save them for the end, whichever works better for you. And I'll certainly try not to fill up the whole hour and a half. I don't think I'd want to hear me for an hour and a half. And I will apologize in advance for my dogs. They protect me from Amazon delivery people, squirrels, random wind blowing, God knows what. But they have been on national news and national public radio when I'm talking about COVID, so they may make an appearance here. So really delighted to talk about Omicron, and if we can figure out how to move the slide. So what I'm going to do is I am going to overlap a little bit with some of the previous presentations just to remind us about coronaviruses and why variants occur, because Omicron is not anything unusual, and nobody should have been surprised about Omicron, and nobody should be surprised if a new variant emerges. This is just the nature of what RNA viruses do. And so I think it's important to understand that, to understand why and how Omicron happened. And then we'll jump into the specifics about Omicron itself, including the epidemiology, the immune escape, and vaccine effectiveness. And so I was reading this morning on CNN about how COVID-19 cases are increasing in the United Kingdom and in Europe after they cut back on some of their prevention and control measures, and how people seem to be surprised about that. And what I find fascinating about that is that's about as surprising as if you were to turn on a faucet and water started coming out, and then you open the faucet more and more water comes out, right? So SARS-CoV-2, the virus that causes COVID-19, has not gone away in the last 2 years. So nobody should be surprised if we cut back on the interventions to try and contain it, that this virus transmission actually goes up. That's exactly what you would expect to see happen. And so we still, it sounds like, haven't quite come to grips with the fact that we're stuck with this virus for a while. So what are coronaviruses? So corona means crown. And the name just comes from the fact that when you look at this virus under an electron microscope, it looks like a crown with these kind of little tufts sticking off them. These are actually the spike proteins that you've heard so much about, and they're responsible for the virus binding to cells and then getting into cells and causing disease. These are RNA viruses, and we'll talk about why that's important. There are 4 different types of them, but only 2 types seem to infect mammals. And those are alpha and beta. They tend to cause gastroenteritis in animals, and for whatever reason, they cause respiratory tract infections in humans. So the natural reservoir for these viruses are rodents and bats. So these are what we call zoonoses, which means that they originate in animals, and somehow they've been able to jump a species barrier and get into humans. The 4 listed at the top of this slide, I won't run through the names, they're not important, but these have actually been circulating in humans for decades, very well adapted for human-to-human transmission, tend to cause non-serious disease, the equivalent of the common cold. And to be honest, before the SARS-CoV-2 pandemic, we actually never used to test for them. We didn't really care about coronaviruses, and you could argue as to whether we should or shouldn't, but we haven't. We still don't know where SARS-CoV-2 came from. It seems most closely related to a couple of different bat viruses, but have yet to identify the intermediate host animal. So for example, for the Middle East respiratory syndrome, we actually know that most humans get this disease from camels, even though the natural reservoir or host animal for this virus is a bat. So the virus actually managed to get from bats into camels, and then from camels into people. In the case of SARS-CoV-2, we haven't found if there's an intermediate step between us and the bats. What we do know is that these viruses bind very well to the ACE2 receptors in human cells. And unfortunately, those receptors are found on a lot of different cell types, including endothelial cells, epithelial cells, myocardial cells, kidney cells. So all throughout the body, there are ACE2 receptors. So a lot of different types of cell types that can become infected with this virus. So why is being an RNA virus important for the discussion today? It's because RNA viruses are more likely to make mistakes when they replicate than organisms based on DNA. So DNA is a better system for replication than RNA if what you're trying to do is avoid changes. So as RNA viruses replicate, they can change, and those changes can be a couple of different things. One is they can be mutations, and you can either have what are called synonymous or non-synonymous mutations. So a synonymous mutation is a mutation where you change the nucleotide, but it does not result in a change in the amino acid. So remember, every amino acid is coded for with 3 nucleotides, and so if you have you change an A to a T, for example, it doesn't necessarily mean that you're going to cause a different amino acid to be placed in that position. So that's one set. The other obviously are the non-synonymous that result in changes in amino acids. The other thing you can have is deletion. So you can have parts of the genetic code that actually drop out, and that happens quite frequently in RNA viruses. The vast majority of time, these changes have no impact on the virus. They don't make the virus more transmissible. They don't make the virus more or less deadly. But when those changes do occur and they result in some ecologic advantage to the virus, then that change can become fixed. That new variant, as we call it, can then become the dominant variant among the virus population. It turns out that coronaviruses actually do this less than some other RNA viruses. So influenza viruses and HIV, for example, which is also an RNA virus, tend to make mistakes more rapidly than coronaviruses, because coronaviruses actually have a proofreading mechanism to try to pick up those changes, but nonetheless, those changes do occur. And so that's just a natural phenomena of the replication of the virus. But the only way a new variant is going to emerge is if somehow those changes confer some kind of advantage to that variant versus all the other variants. So what are variants? So variants are just SARS coronaviruses with different genomic sequences, right? So they're just some kind of mutation. Could be one, it could be multiple. So one of the variants that we talked about last year was Alpha, which was last summer the dominant variant circulating around the United States and most of the world. And in the spike protein alone, there were at least 13 documented changes, as well as some changes elsewhere in the virus. And so you can have multiple changes that result in a variant, and not all of the changes are equally important. The reason why changes in the spike protein are so important is because that's the part of the virus that the immune system tends to recognize. And that's also the part of the virus that binds to the receptors that allows the virus to get into cells and infect cells. So usually changes there are very important because they can affect the immune response, or they can affect the ability of the virus to get into a cell. Because that's the part of the virus that's recognized by the immune system, that's also why you tend to get more changes in that part of the virus than, say, the nucleocapsid, because that virus is under immune selection pressure. So just like antibiotics can result in the emergence of resistant bacteria, having an immune response that's trying to stop viral replication can lead to the selection of viruses, that variants that are not recognized by that immune response. So it's that same kind of a selective pressure operating. And that's why so many of the changes that we talk about with the different variants are occurring in the spike protein, because that's the part of the virus that's most under immune pressure. So what about when these happen? So this has actually been going on since the start of the pandemic. So we haven't really thought about it much until Alpha and then Delta and now Omicron. But in fact, the variant that spread through most of the world in the spring of 2020, which seems like forever ago now, doesn't it just seem like a whole different lifetime? But it was actually a variant. So there was this change called D614G, which just refers, the D and the G refer to the amino acid. So you switched an aspartic acid to a glycine. And the 614 refers to the position on the spike protein RNA, the RNA for the spike protein. So at that particular point in the protein, you had a switch in an amino acid, and that facilitated the ability of that protein to bind much more efficiently to the ACE2 receptor. And so what happened was you now had a change in the virus that conferred an ecologic advantage to that variant relative to other strains of the virus that were out there circulating. And so sure enough, it was able to outcompete and become the dominant variant around the world. So how do we think about these variants now? The World Health Organization and the US Centers for Disease Control and Prevention divide them up into 4 groups. One group is called variants being monitored. And these are mainly made up of what used to be variants of concern that have essentially been pushed out by Omicron. So they're really not circulating anymore because Omicron has been able to outcompete them. But a lot of them are ones you're probably familiar with. Alpha, certainly everybody's heard of. Beta was the one in South Africa. Iota was first described actually in New York. Mu was described in Peru and Colombia. But all of these at one point or another had demonstrated the ability to have increased transmissibility and or increased disease severity, or possibly be less affected by our treatments or our vaccine. So they had some change that made them potentially either more easy to spread, more deadly, or less easy to be protected against by vaccines or treated. The good news is, fortunately, most of these are not really circulating to any extent right now. Variants of interest are variants where we find that they have mutations in them that are similar to mutations that we know could have negative properties, such as increased transmissibility, but these variants yet really haven't caused any problem. So we're kind of watching them, but we think they might be able to cause problems, but they haven't yet. So variants of concern are the ones where not only do they have either increased transmission or they cause more severe disease or reduced effectiveness, but they're actually spreading too. And at the moment, we have two of those, Delta and Omicron. But to be honest, Delta's not really spreading at all. So it wouldn't surprise me if at some point Delta gets moved like Alpha did before it, from being a variant of concern to a variant being monitored. And the last group, and the most serious group, are the variants of high consequence. So these are new variants that arise where basically our vaccines don't work anymore. And knock wood, we haven't had those yet, but Omicron's come pretty close to that. So it wouldn't surprise me if at some point we do see a variant of high consequence. That would not be shocking or unusual. So what about the variants of concern? So Delta, not going to spend a lot of time on today, originally described in India. Data to show, we talked about it, I think the last time, more transmissible, probably increased virulence as well. So probably more likely to cause serious disease than Alpha, but really no big change in vaccine effectiveness. The vaccines seem to work just as well against Delta as they did against Alpha and what came before it. And that was true for most of our treatments, particularly the monoclonal antibodies as well. So Omicron, which we're going to spend most of the time on today, was first described in November of 2021, I believe it was. You know, the years just all blend together now. We've been in COVID for so long. Also known as B11529. I think most people would agree now. So at the time that I put this together, the data was suggesting probably more transmissible than Delta, but we have more data. I think it is a little more transmissible than Delta, but the big difference between Omicron and the variants that came before was immune escape. So there are two ways that a virus can be spread more easily than what's come before it. So one way is that somehow there's a change in the virus, that it either there's more virus or it binds more readily to cells. But another way that a virus could spread more easily is the ability to infect people who are protected against other variants. And we call that immune escape. And that really seems to be the important difference with Omicron. So yes, Omicron is probably a little more transmissible than Delta, but what really separates Omicron from Delta is Omicron's ability to cause disease in people who've been infected with other variants of SARS-CoV-2, so Alpha or Delta or D614G, or people who've been vaccinated. So people who have immune protection against earlier variants, we're finding that, in fact, Omicron can still cause infection. Now, we have to separate out infection from serious disease, and we'll talk about that as we go forward. But Omicron is able to cause infection in people who are protected against other variants. So let's talk about some of those data. So what is Omicron? So Omicron first, as I said, actually first probably recognized in Botswana, which, if you remember your geography, is right next to South Africa, but then described in South Africa. So it has at least 32 changes in its spike protein. Now, not all of those changes are going to be important or equally important, but a number of those changes are probably what are driving its ability to escape from the immune system that some of the previous variants have not been able to. But changes don't just happen in the spike protein, they can happen elsewhere too. And in fact, Omicron does have changes in its membrane protein, the nuclear capsid, and other places as well. So this is a substantially different version of the SARS-CoV-2 virus than what we've seen earlier. And when it was initially described, what they found was this very rapidly replaced Delta as the predominant version of SARS-CoV-2, so that in the course of about a month, it was responsible for essentially 100% of all COVID cases. And I'll show you the data for the US, where something very similar happened. But one of the things that they noticed was, at least initially, there seemed to be a lower risk of hospitalization or death with Omicron compared to the earlier waves of COVID-19 that they had seen in South Africa. So the Omicron wave was actually the fourth wave of COVID-19 to spread through South Africa. But there seemed to be a decoupling between case numbers and hospitalizations and deaths. And actually a very similar thing happened in the United States as well. So here are the data from about a week ago in the US. So Omicron actually has what are called sublineages, which are slightly different changes to the version, but the changes aren't sufficient enough to be called an entire new variant. So we just call it a sublineage. And the big ones that we worry about with Omicron, there are actually about 5 or 6 of them, but there are 3 in particular that we're really focusing on: the BA 1.1, the BA 1, and the BA 2. And what you can see here from November 27, 2021, the United States, when essentially all of the COVID in the United States is Delta. So this yellow is Delta. So in November, essentially all we have is Delta, and that had been true for months. Delta just pushed Alpha and everything else right off the table. But you can see over the course of a week, just all these different purples are just the different versions of Omicron. Omicron, from essentially not existing, just very rapidly replaces Delta. And what you can't see, I can't see on my screen because you guys, I'm looking at all your faces, you're kind of blocking my screen, but somewhere over here, BA2 is increasing, and BA2 is actually rapidly rising. And it wouldn't surprise me if over the next few weeks, BA2 becomes the predominant version of Omicron in the United States. And so just as before, there was essentially nothing but Delta in the United States. At this point, there's nothing but Omicron. So all the COVID-19 in the US right now is Omicron. And even though we're doing much better than we were before, so in January of this year, we were averaging up to almost 800,000 cases of COVID a day. Right now, we're averaging about 32,000 cases a day. So in the US as a whole. So even though we're way down from where we were, this virus has not gone away, right? So we're still averaging 1,000 cases a day of COVID in Los Angeles. And everybody seems to think SARS-CoV-2 has gone away. It's not gone away. It's still out there. And so don't be surprised if case numbers go up again. So one of the differences about Omicron is there seems to be a lot more asymptomatic carriage. So this is a study done again in South Africa where they were doing vaccine trials. So as part of the vaccine trials, they routinely did PCR tests on everybody, whether they had symptoms or not, to look for SARS-CoV-2 virus. And what they found was that in general, during the Delta, when Delta was the predominant strain, about 2.5% of people who had no symptoms at all, felt totally fine, who they were enrolling in the trial, were positive for SARS-CoV-2 by PCR. When they got into Omicron, same trial, same procedures, what they found was that almost a third of people were positive for SARS-CoV-2 virus, the Omicron variant, but they had no symptoms. So 71 out of 230 people they were trying to enroll this trial were asymptomatic, but actually infected with SARS-CoV-2 virus and potentially infectious to others. So they could spread this virus to other people. And that's a big change between what's going on before with Delta. So there could be more Omicron spread going on out there than we actually realize. So we think there are about 1,000 cases a day in Los Angeles County, about 32,000 in the US as a whole. But because there may be more asymptomatic infection, those numbers could actually be higher than what we realize they are. And that may not be important for otherwise young, healthy people, but we're going to talk about pregnant women at the end. Pregnant women are at increased risk for serious disease from COVID-19. And so if there is asymptomatic transmission going on, there are potentially people out there who could be exposing pregnant women to COVID-19. So what about trying to tease out this difference between, is it more transmissible or is it immune escape? So one of the ways we try to do that is we look at how the virus spreads, and a good way to try to get a handle on that is to look at household contact. So this is a Danish study that was done at the end of 2021, where they looked at household contact spread between when Omicron was the predominant variant and when Delta was the predominant variant. And as you can see, the Omicron secondary attack rate was higher than the Delta. So what this means is roughly 1 out of every 3 people in the same house got infected with Omicron when the index case had Omicron, as opposed to 1 out of every 5 persons in the same house if they were infected with Delta. But it's a little more complicated than that, because if you start to break it out by whether or not the household contacts were vaccinated, what you found out with Delta was that the unvaccinated people were much more likely to be secondarily infected than the vaccinated household contacts. So 2.3 times more likely to be infected. Vaccines were associated with a 62% protective effect from getting a secondary case. But with Omicron, what we found was fully vaccinated people had essentially the same risk of infection as unvaccinated people. So the vaccines weren't protecting against infection from Omicron at all, with the exception of people who had gotten a booster. So if you'd gotten a booster on top of being fully vaccinated, so the CDC defines fully vaccinated as having gotten 2 doses of an mRNA vaccine, either the Pfizer vaccine or the Moderna vaccine, and being at least 2 weeks out from that, or at least 2 weeks out from having gotten 1 dose of Johnson & Johnson. So that's the definition of fully vaccinated that the CDC uses, and I'll be using in these slides. But in fact, if you really want to be optimally protected against Omicron and SARS-CoV-2 as a whole, we know that if you're more than 4 to 6 months out from your vaccine series, you really need to have had a booster as well. And in fact, the boosters did seem to protect against infection in this study, not as well as they protected against Delta, but people who had received a booster were about half as likely to have a secondary infection than people who had not been boosted. So what we saw, Omicron versus Delta transmission, was that in the unvaccinated people, really not a big difference between Omicron and Delta, a little higher with Omicron, not quite statistically significant, but that's probably a power issue so Omicron probably is more transmissible than Delta. But where the big difference was in the vaccinated. So the fully vaccinated people were over 2.5 times more likely to be secondarily infected if they were exposed to Omicron than if they were exposed to Delta. And the boosted vaccinated people were almost over 3.5 times more likely to be infected. So what's going on there? What's going on there is immune escape. And we'll kind of run through some of the laboratory data to demonstrate that. But what it's telling us is that not only is Omicron a little more transmissible than Delta, and remember, Delta was more transmissible than Alpha, and Alpha was more transmissible than D614. So this virus is getting better and better and better at spreading among people, okay? And so it's actually going in the wrong way. And I'll just take a moment to take it aside. There is this myth, for lack of a better word, that as viruses become more transmissible, they become less pathogenic and deadly. And that is complete nonsense. There is no correlation between transmissibility and pathogenicity, okay? It just all depends on the properties introduced by the mutations. So you can have a virus that becomes more transmissible and is more pathogenic. You can have a virus that becomes more transmissible and less pathogenic. And you can have a virus that becomes more transmissible and no change in its pathogenicity. So no correlation between pathogenicity and transmissibility. They're 2 different viruses. And the classic example of that is HIV, right? HIV has been circulating in humans for 40 years, for 40 decades. It's no less deadly today than it was 40 years ago. The big difference is we have highly effective treatments now that we didn't have then. So when you hear people talking about, oh, you know, that's okay that SARS-CoV-2 is mutating and becoming more transmissible because it's just going to become less pathogenic. No, does not have to happen that way. Could happen, but doesn't have to happen. So just be aware that those are different properties. So what do we know about virulence and Omicron? So this is a study again out of South Africa, and the reason a lot of the original data are from South Africa is that's where Omicron was first recognized, and we're still pretty early on in learning about Omicron. So here, over 31,000 proven cases of Omicron, and what they found was that so CT stands for cycle threshold. So when you do a PCR test to look for the SARS-CoV-2 genomic material, one of the things you can do is you can count how many times you have to amplify before you actually detect the RNA in this case. And the fewer number of times you need to amplify, the more virus is likely to be present. So it's a inverse correlation between how much virus. So the lower the cycle threshold, the higher the amount of virus in the person. So what they saw was that in general, Omicron tended to have lower cycle thresholds on PCR tests than Delta, suggesting that people infected with Omicron had more virus present than people who were infected with Delta. That having been said, the risk of hospitalization with Omicron was only 20% of the risk of hospitalization with Delta. Once you got into the hospital, though, there was really no difference in outcome. So much less likely to need to go to the hospital, but if you did end up in the hospital, your outcomes weren't that different between Omicron and between Delta. So what's going on here? What's going on is probably the complexity of the human immune response. So if most of the studies, when we talk about immune response to coronavirus, we talk about what are called neutralizing antibodies. And neutralizing antibodies are critically important for preventing infection. However, neutralizing antibodies are not the only defense we have against preventing disease, particularly serious disease. We also have memory B cells and we have T cells. But memory B cells and T cells tend not to respond as rapidly as neutralizing antibodies. And so they're less good at preventing infection, but that doesn't mean they aren't good at preventing serious disease. And so probably what we think is going on to explain these data from South Africa is that the vaccine, so at this point, about 20% of the South African population have been vaccinated, but it was estimated that a majority of the people had been previously infected with COVID-19. So between the vaccine immune response and the previous infection immune response, most people had some protection against Omicron. And while that protection wasn't necessarily very good at stopping disease, at stopping infection, it was probably reasonably good at stopping serious disease. And so can we tease that out? So if we look at some laboratory data, so here what you're looking at is you're looking at neutralizing antibodies. And so you're looking at A is after, this is the Moderna vaccine, 4 to 6 months after being fully vaccinated. You're looking at the levels of neutralizing antibodies to alpha, to beta, to delta, and to Omicron. And they estimate that right about here is the level you need to be protected. And what you can see is that the neutralizing antibody levels to Omicron are probably below the level you need for protection 4 to 6 months after being vaccinated with the Moderna vaccine. This is the exact same data, but here you're looking at the AstraZeneca adenovirus-based vaccine. So this vaccine is not available in the United States, but it is actually the most commonly used vaccine in the world right now. So for most of the world, the AstraZeneca vaccine is the most commonly used vaccine. Again, same thing. But this is 1 month out after two doses. You could, so unlike the Johnson & Johnson, which is a 1-dose vaccine, the AstraZeneca adenovirus vaccine is a 2-dose vaccine. You can see high levels against alpha, beta, delta, very low levels against Omicron. Same thing now, 1 month after 2 doses of the Pfizer vaccine, and then this one's off the screen, but this is 1 month after, I don't know, is there some way to make this go away? Then I could actually, let me see if I can see it. Okay, so this is also 1 month after 2 doses of the Pfizer vaccine too. At the bottom set, what you're looking at across the slides is people who have been infected with SARS-CoV-2 virus. So this is convalescent sera from people who were infected with the Alpha variant. This is convalescent sera from people infected with Beta, people infected with Delta, and exactly the same thing. So just like vaccine, protected against the earlier variants, not really protected in terms of neutralizing antibodies against Omicron. So that's why we think immune escape is really what's driving it. The good news is, though, that if you take someone who's been previously infected with SARS-CoV-2 and you vaccinate them, what you see is you get a nice response of neutralizing antibody even against the Omicron variant. So you get a nice bump in the neutralizing antibody response. So these are just some more data looking at the effect of boosters. So again, we're looking at neutralizing antibody titers over time. And this is comparing the D614G, so the original sort of variant that kind of swept through in the spring of 2020 versus Omicron. And this is percentage of neutralizing antibody. And so we're talking about, these are all with the Moderna vaccine. And so this is 1 month after 1 month after second dose. So you should be fully vaccinated here. And you see much lower levels of neutralizing antibody against Omicron than against the D614G. And then this is 7 months later. So a little bit of fall off over time, we know that, but still very low for Omicron. And then this is a booster. And what you can see is if you give a booster, you do get a nice response. This is 1 month after booster. This is 6 months after booster. So nice response with the booster dose. And then what they did down in the lower slide, exact same thing, just different doses of booster. So remember, the Moderna booster is a half dose compared to the original vaccine, 50 micrograms instead of 100 micrograms. And you can see no real big difference between the two. And then these are just different versions of the Moderna vaccine, all equally giving a good response with a booster dose, suggesting that in fact, boosters will in fact increase your neutralizing antibodies against Omicron. So what about out in the real world? Did they see any benefit at all from the vaccines in terms of Omicron? So again, another study from South Africa between November, December of last year, at least 14 days after 2 doses. So these are people who have been vaccinated relatively recently, not necessarily 4 to 6 months out from their vaccinations. And what they found was, in fact, yes, there was protection against Omicron, 70% effective against hospitalization, though this was lower than what they saw against earlier variants like Delta, where the protective effectiveness was over 90%. It was also 50% effective against any COVID symptoms at all. So the vaccines do provide protection against Omicron. They just don't work as well against Omicron as they have against some of the earlier variants. So what other data do we have? So these are data from the UK, over 1 million cases of COVID-19 PCR. So remember, in the United Kingdom, they had 2 vaccines. They had the AstraZeneca adenovirus vaccine, and then they had the Pfizer vaccine. So the initial vaccination was either with AstraZeneca or Pfizer. And then for boosters, they used either AstraZeneca, Pfizer, or or Moderna. And so what you're looking at the tables up here, so these are people who were originally vaccinated with AstraZeneca and then boosted with either Pfizer or Moderna. And what you see is the vaccine effectiveness declines over time, whether it's Omicron, so the gray circles are Omicron, the black squares are Delta. So over time, protection against Delta starts very high, over 80%, but over 25 weeks declines down to about 50%. But against infection with Omicron, you're already starting out closer to 50%, and then essentially dropping down to 0 over 25 weeks. If you boost people who got AstraZeneca with Pfizer, you see protection bumps right back up over 10-week period. Also bumps up for Omicron, but not as high. Exact same thing if you boost with Moderna, bumps up over 9 weeks here. Omicron, not quite as good a response, but around 60% effectiveness if you boost with Moderna. So these are the exact same data, only these are people who were vaccinated initially with the Pfizer vaccine. So again, you see the fall off with the Pfizer vaccine is not quite as steep as it was with the AstraZeneca, but again, Omicron, less effective for Omicron than for Delta. But again, if you boost with Pfizer on top of Pfizer or Moderna on top of Pfizer, you do get benefit, get much more effectiveness, but less for Omicron compared with Delta. And then the last is a smaller group in the UK, more recent data of people with Moderna as the original vaccine and then boosted with either Pfizer or Moderna. Again, seeing the same exact effect across all three vaccines. These are data from Israel, where they've been using the Pfizer vaccine almost entirely in the country. And these are people who've actually got a 4th dose of vaccine, so a second booster on top of the first booster. And they're individuals greater than or equal to 60 years old, had gotten at least 3 doses of the Pfizer vaccine at least 4 months ago, and then got a 4th dose of Pfizer, looking at what happened with Omicron. And so you see, and these are days since a 4th dose, so sort of initially no protective effect. And we think it takes somewhere between 9 and 12 days before the immune response starts to kick in. But what you see is, compared with people who had only had 3, elderly people who had only had 3 doses, after you get about 12 days, you see increased protective effectiveness against Omicron with a 4th dose compared to people who've only gotten 3 doses, suggesting that you can stimulate the immune system with extra doses of vaccine. But the real question is whether or not we should be using a different version of the vaccine, whether we should be updating the vaccine just like they do for influenza every year. And as you probably know, either late last week or earlier this week, the CEO of Pfizer said they anticipated going for approval of an Omicron specific booster from the FDA in the coming weeks. So that will likely be coming down the pike very, very soon. So let's talk a little bit about monoclonal antibodies. So there are 2 major categories of monoclonal antibodies that we use. So one is what's called Evusheld. So this is a combination of 2 monoclonal antibodies, tixagevimab and silgevimab, which we use primarily in people who don't respond to vaccines, right? So these are not to be used instead of vaccination. Anybody who can be vaccinated should be vaccinated. But if you're if you're greater than or equal to 12 years old and you weigh at least 40 kilograms, which is about 90 pounds, in our immunocompromised patients in particular, so where we've used these are, for example, our solid organ transplant patients or our patients getting chemotherapy for cancer who may not respond to a vaccine. This combination of monoclonal antibodies is given every 6 months to prevent them from getting COVID-19. So this is actually a prevention matter. But when we look at in the laboratory at the effectiveness of this combination at neutralizing Omicron, what we find is that you need much higher levels to up to 140 times higher levels to neutralize Omicron than to neutralize earlier variants. And in fact, the FDA about a month ago recommended doubling the dose of Evusheld because of the rise of Omicron. And then just a reminder that not a substitution for vaccination. The good news is that our antiviral treatments do not seem to be affected by the mutations in the spike protein. And that makes sense because, for example, Paxlovid is a protease inhibitor. And so there's no reason, if there aren't mutations in the protease, that it should necessarily be affected by mutations in the spike protein. So that seems to be equally effective against Omicron, as is molnupiravir, which is the Merck mutagenesis drug, does not work as well as Paxlovid or nirmatrelvir. I don't know how I would say that, but that's probably close enough. So at least, and same with remdesivir, which we use primarily in the hospital, but has also been authorized for use in people infected with SARS-CoV-2 at risk for serious disease. These other two monoclonal antibodies, sotrovimab and batelovimab, are actually used as treatments, not preventive therapy. So whereas Evusheld is given to people who are at risk for infection, we use these two monoclonal antibodies, people who have been documented to have infection with COVID-19, but are at high risk for serious disease. And so we give them these monoclonal antibodies to try to prevent them from getting serious disease. But again, while they still remain active against Omicron, we do find that the neutralization is lower, and you have to have higher doses, 4 to 14 times higher, to get the same effect in the laboratory as what you would see against Delta or Alpha. So in general, if someone were, say, if a pregnant woman were to come into the hospital, for example, with COVID-19, we would be more likely to use one of these top three agents than to use one of these. So what about pregnancy and COVID-19 vaccine? So as you probably know, and I think we've talked about before, pregnant women are about 3 to 4 times higher risk for serious disease, hospitalization, and death, including ending up in the ICU and on ECMO, compared with women of a similar age and otherwise similar health who are not pregnant. COVID infection is also now associated with premature birth. So those are the two major things that we worry about in terms of COVID infection and pregnancy. So there are now very good data to show that the vaccines do work in pregnant women. So they will reduce the risk of serious disease, hospitalization, and death. They do decline over time. The effectiveness does decline over time, just as it does in non-pregnant individuals. There is no way you can get COVID-19 from any of the vaccines in the United States. So the 2 mRNA vaccines and the Johnson and Johnson adenovirus-based vaccines, which we tend not to recommend unless people can't get an mRNA vaccine, are not live viral vaccines. They can't cause replicant virus to occur. So there's absolutely no risk of getting SARS-CoV-2 from the vaccines, despite what you may have heard. They're increasing data now from a variety of safety studies that have been done, showing no association between vaccination and preterm births or miscarriage, and limited data yet, but no signals to suggest any risk of birth defects. So these vaccines to be very, very safe in pregnant women. Sadly, only about 60% of pregnant women in the United States are fully vaccinated against COVID-19. And as someone who has personally taken care of pregnant women with COVID-19 who have had to go on ECMO, that is not a position you want to be in. You do not want to be 26 weeks pregnant on ECMO, on a ventilator, in the ICU. That's just not where you want to be. So somehow we got to get that 60% up to 100%. So what else do we know about vaccination? What we do know is that mothers do generate neutralizing antibodies, and that these neutralizing antibodies look like they in fact do cross the placenta, and you can detect these neutralizing antibodies in babies after birth. And so if you vaccinate moms, particularly early in pregnancy, this first study was not early in pregnancy, but if you vaccinate moms in pregnancy, they do generate neutralizing antibodies, and those neutralizing antibodies can be found in babies afterward. And there are now some data, so this was actually just published in the last couple of weeks, to suggest that those neutralizing antibodies are in fact protecting babies from getting COVID-19. So this was a study just published at the end of February in the MMWR that found that moms who had been vaccinated, particularly in the third trimester, their babies were much less likely to be hospitalized with COVID-19 than moms who had not been vaccinated. But the vaccine provided protective effect anytime during pregnancy. So overall, the effectiveness was 60% lower risk of a 61% lower risk of being hospitalized with COVID-19. But there did seem to be a trend to suggest that later in pregnancy lasted longer after birth than earlier in pregnancy. And that's not surprising. We know in pretty much everybody, the effectiveness declines over time. So it's not surprising it declines over time after babies are born as well. So just to sum it up, and then we'll have about 20 minutes for questions. Omicron is the COVID story right now, not just in the United States, but the entire world. BA2 is increasing both globally in the US, and probably a little more transmissible than even the original Omicron. And I wouldn't be surprised if by the end of March, it's certainly the majority of all cases in the United States, if not having pushed everything else. There are data to show that while the vaccines are less effective at preventing infection from Omicron, they still seem to be reasonably good at preventing serious disease, hospitalization, and death. So that's 70% effectiveness from South Africa, for example. that boosters improve effectiveness, and in the laboratory, we can find that they raise the level of neutralizing antibodies, which are important for preventing infection, even if not necessarily the only thing we have to protect us against serious disease. And our antivirals still do work. They are becoming increasingly available, particularly Paxlovid is becoming more available. I think that's really terrific news. So we will have more treatment options going forward, but again, no substitution for vaccination. Unfortunately, most of our monoclonal antibodies that we have do not retain activity against Omicron 2, but we still have some, like Stratrovimab, which do have some activity against Omicron. So we're not completely up the creek without a paddle. And then finally, don't be surprised if a new variant emerges. That this virus is still replicating, and anytime it replicates, there's the opportunity for a mutation to occur that could confer some kind of advantage on the virus and allow that mutation to spread. So I think that's it. I'm delighted to open it up for any questions, and I'll stop sharing the screen.
Great. Thank you so much, Dr. Brewer. Let's all give Dr. Brewer a round of applause virtually here. Thank you for going through that. I think I have always felt through all of these webinars that you give confident and more confident than when I came into it, and feeling more under, just having the basis and understanding of what's happening, I think can be really empowering and helpful for everybody. So I hope everybody else feels that way too. We have a few questions in the chat, so I'll start with those. And then if you come up with follow-up questions as we're going through those, and if so that sparks something for you, you can add that to the chat as well, or unmute yourselves and share those. So I'll start with the ones in the chat, and I also have a few of my own that I've kept a list of too. So starting with one up here from Marlene, does the booster just decrease hospitalization and symptoms, or does it also decrease transmission rate in those who are boosted versus unvaccinated?
Yeah, terrific question. We don't know for sure yet, but we think that it probably does decrease infection as well, but we're still looking to see that. And the reason we think that is, if you remember the slides from the laboratory, you saw that the booster did increase the neutralizing antibody levels against Omicron as well as earlier variants. And we think it's the neutralizing antibodies in particular that are important in preventing infection. So, and if you prevent infection, you will prevent transmission. So we think so, but that's really extrapolating from the laboratory data, and we still need to get the population-based data.
Great, thank you. Marlene, if you've got follow-ups for that, feel free to put those in the chat. The next question that came up from the chat was from Joyce, and she's asking, or saying that she's been hearing from people that have been hospitalized that remdesivir has been the cause or has led to organ shutdown and failure. Do you know more about this? Can you explain anything about that, the science behind it, if that's the case?
So remdesivir is actually a relatively safe drug. The main side effect of remdesivir is hepatitis, inflammation of the liver. And so we tend to watch that very closely, particularly in pregnant women, because pregnant women are at increased risk for liver inflammation. SARS-CoV-2 causes organ shutdown. So, right, if you're seriously sick, then the primary organs affected by SARS-CoV-2 that we tend to see are the heart, lungs, and kidneys. So those are the ones that seem to be most infected. And much of our population hospitalized with COVID-19 tend to be very old, and they tend to have comorbid disease. So even though case numbers are higher in 18 to 49-year-olds, hospitalizations remain much higher in people over the age of 65. In the pregnant women that I've taken care of, you have to remember I'm an infectious disease doc, and so I have what's called ascertainment bias, and that just means the critical care doctors and the hospitalists are only going to get me involved if things are going wrong, right? So I'm seeing the worst possible cases. So you can't extrapolate from my experience, but in the pregnant women that I've taken care of in the ICUs with organ failure, most of that I'm convinced is actually from both the original infection and the immune response to the infection, because at that point most of them actually aren't on remdesivir anymore.
Great, thank you for that answer. I think that's helpful. Joyce, if you've got extra follow-up, feel free to unmute or put that in the chat. I'm gonna go to a different one that I had written out, and since we're on it already, or you're mentioning pregnant women, I think that's an important just area to focus on briefly here. So you mentioned about kind of getting the vaccine during pregnancy at any point and how that can be really useful, and how we really need to increase that 60% vaccination rate among pregnant women. Do you have any specific advice for women who become pregnant after they've already been fully boosted? So is there anything specific that they need to be, special precautions, things like that, different,
Sure.
different things?
So, yeah. So at this point, we're not, the FDA and the CDC are not recommending additional boosters. I wouldn't be surprised if that happens at some point, especially if Pfizer releases an Omicron version of the vaccine. So one thing I would recommend to you all as healthcare providers is just keep an eye out for that, to check in with either the county public health department website or the CDC website for announcements about should we be giving fourth doses. That won't surprise me if that happens sometime in the spring or summer. The other thing you can remind them is that transmission primarily occurs indoors rather than outdoors. So they might want to consider wearing a mask when they're shopping in supermarkets and other indoor places, trying to maintain their physical distancing still. That works just as well against Omicron as other variants. Good hand hygiene. And then staying away from people who are sick. So if mom or dad is sick and you're pregnant, you say, hey mom, don't come to visit until you're feeling better. So all of those are things that you can do to reduce the risk.
Great, thank you. I'm gonna keep on the mother path here for a second, and then we'll go back to some of the other ones in the chat. So what's the best way to educate mothers who are against the vaccines, and how should we go about this, or how should they go about this with their school-age children, with schools that may mandate these vaccines?
Sure. So I think what you want to try to do is understand, why are they against the vaccine? What is it that they're worried about? Because they've likely had their children receive lots of vaccines, right? So you can't go to school in California without getting lots of different vaccines, including diseases that they've never probably seen in their life, like polio. I suspect most of them have never seen a case of polio, and it wouldn't surprise me if many of you have never seen a case of polio, right? We haven't had a case of polio in the Western Hemisphere since 1993, and that was in Peru. And I can't tell you when the last time we had a polio case in the US. But they don't think anything about it. They just say, oh, my kid needs the vaccine, they get it. So what is it about the COVID-19 vaccine that they're concerned about? And if you can understand that, then you can probably address it. The single most important thing, though, is going to be trust. If they trust you, they're more likely to get vaccinated than if they don't trust you, right? So that's fundamentally what it boils down to. And you're going to be much better at it than I am, because you're going to have this relationship with them over time and build up that trust. And that's what's going to allow you to convince them to get vaccinated rather than any specific facts. But knowing the facts is helpful. So one of the things I got asked recently about was, there's this rumor going around that the vaccines cause the blood to congeal. I don't know if you guys have heard this, but it's like this horrible congealing of the blood, and people are even like posting things on the internet. Complete nonsense, right? So these vaccines have been given to over 220 million people in the United States. They've been given to 4.3 billion people around the world. We have a lot of data about them. The Pfizer and Moderna vaccines are now fully FDA approved. They're no longer under emergency use authorization for people 18 and older. They're fully approved vaccines now. So just trying to figure out what it is that's driving them and tease that out will be helpful.
Thank you. And I think part of that's helpful too is just if it's fear of something happening to themselves or their child, which I'm sure that's a big piece of that, like a health risk. Can you explain some of the other, like you mentioned, being pregnant in the hospital in the ICU with COVID is incredibly risky and obviously very unsafe. So are there other things that might kind of tip the scales? And if it's a fear for the safety, what are the other things that could happen?
So the other thing to say is, it's much worse to have COVID-19 than to have the vaccine, right? So one of the things people talk about is myocarditis. Oh, I don't want to get myocarditis, particularly the risk is highest in young men between the ages of about 17 and 30. Well, and the risk, depending on the study that you look at, is somewhere in the neighborhood of maybe as high as 3 per 100,000 people vaccinated. But the risk of myocarditis if you get COVID-19 is about 3 to 11 times higher than the risk from myocarditis from the vaccine, right? So if you're worried about myocarditis, you want the vaccine because, Omicron is ripping through the population, and it's highly likely that you're either vaccinated and you're going to get Omicron, or you're unvaccinated and you're going to get Omicron, but you're not going to dodge Omicron, right? And so if you're worried about myocarditis, getting vaccinated has a much lower risk of getting myocarditis than if you get the disease. You can't get long COVID from the vaccine. Somewhere between 20 and 60% of people end up with long COVID. So they end up with fatigue after they're better. They end up with muscle aches. They end up with kidney disease. Not as much of a risk factor for your population of young women, but in older men. So there's a study now out of the VA system that people who've had COVID in the year after they have COVID have a much higher risk of having strokes, heart attacks, and cardiovascular disease than if they didn't have COVID, right? So your population isn't as at risk for those problems, but they are at risk for long COVID. And you can't get long COVID from the vaccine. So getting vaccinated protects you against long COVID. Blood clots. So a lot of pregnant women are worried about blood clots. The risk of blood clots has been associated with the Johnson & Johnson vaccine. That's why we don't recommend it as the primary vaccine anymore. But that risk is somewhere in the neighborhood of about 7 blood clots per million vaccines. The risk of blood clots with COVID is about anywhere, it can be as high as 20% of people who get COVID, depending on how sick you are, if you end up hospitalized, for example. So if you're worried about blood clots, again, much higher risk of getting blood clots if you have COVID than if you have the vaccine. So I think that's the way you need to frame it, is that, it's always worse to have the disease. And that's true for kids too. So the multi-inflammatory syndrome that kids get, that doesn't happen from the vaccine, but it can happen from getting COVID. So protect not only you, but also your children.
Thank you. What a nice, nicely laid out argument that was. That was great. Can you just clarify the when you're using the term long COVID, what that specifically the diagnosis of that is?
Sure. So long COVID is a collection of symptoms. It's in that sense, it's a little bit like chronic fatigue syndrome, and in that we don't know exactly what's driving it, but what we know from looking at studies of people who've had COVID-19, including asymptomatic infection, is that somewhere between 20 to 60% of them will report ongoing problems over time after the COVID has resolved. And these studies have now followed people out for as much as 6 to 8 months. And what they find is people complain of things like brain fog, fatigue, lethargy, but there are also documented problems like increased risk of kidney dysfunction. So you can show that people's renal failure has fallen off after having COVID than compared with before COVID. And I mentioned about the cardiovascular disease in older age groups. So there is some kind of long-term damage. We don't know if that's from the virus itself or the inflammatory response and from the immune system in response to the virus. It does seem to decline over time. So over time, the symptoms of long COVID seem to get lessened, but you can find as much as 6 months, 8 months after COVID, as many as 30% of people still aren't back to normal. They still aren't back to what they were before they had COVID.
Great, thank you for that explanation. Shifting a little to children under 5, what do you know about any studies for infants and children up to the age of 5? Is this being studied? What is the current advice around that?
So there are vaccine trials ongoing. The initial trials did not seem to show any particular benefit from vaccination, and the possibility is that the dose of the vaccine may have been too small. So the vaccine dose was cut for 5 to 12-year-olds, the Pfizer vaccine, and then it was cut again for the under 5s. It's possible that the dose was just too small. It looked good in the preliminary studies, but it may be not enough to generate an effective immune response. So I don't know where those trials stand right now, whether they're being repeated with a larger dose or not. But we still don't have approved vaccines for children under the age of 5. Children under the age of 5 seem to have lower rates of serious disease from COVID-19. Seems to be more likely to be asymptomatic disease. And they also seem to be less likely to transmit COVID to others compared with older children and adults. But I think the big concern in that age group is the multi-inflammatory syndrome that can occur after COVID-19.
Okay, thank you. We're getting close to our time here, so I'm gonna we have a lot of additional questions we won't have time to get to today. So, but I'll end it with this one. It's an interesting question. You can't, I know, and it's written this way, I know you can't predict the future, but if you could, what do you anticipate regards to another surge? Like, do you anticipate another significant surge with another variant, just given history and how viruses work?
So I think we will definitely have another surge in the winter. And the only thing I'm not sure of is whether we'll have a surge before then or not. So if you look at 2020 and 2021, we did have surges in the summer as well. I'm not sure that will happen. I think that'll totally depend on whether or not a new variant emerges. But I think we will see a surge going into winter, similar to what happened in 2020 and 2021. So our highest case rates for Delta and Omicron both were starting after about Halloween and running through about the middle of January. With Delta, they peaked around 250,000 cases a day. With Omicron, as I said, it got to almost 800,000 cases a day. And I think this late fall, early winter, we'll see that happen again, as we get into respiratory viral season.
Thank you. I guess we've got some time to prepare then and think about that. But yeah, sounds good. I appreciate, Dr. Brewer, again, just all the support you've given our network and number of different webinars that you've provided. So thank you for another really interesting conversation. Thank you to all of you RNs who were here and provided such great questions and discussion. I really appreciate all of your engagement with this webinar. So unfortunately, we're out of time now, but we may have Dr. Brewer back. We seem to invite him back a lot, so I'm sure we'll see him again, and we can continue to ask him questions in the future. So I put the link for the evaluation in the chat. Please that will be anonymous, so please fill that out if you can, and we'll send the results to Dr. Brewer so that he can see those. We'll also put the slides and the recording and contact info on the blog with the rest of the series so that you can share with new staff members or someone who missed the webinar today. Okay, sounds good. Thanks again, Dr. Brewer. Really appreciate your
Thank you
time.
for having me. I really appreciate it. And if you have any burning questions, something important you're not sure about, just fire me an email. I'm happy to try to get it for you. All right, take care.
Thank you so much. Thanks, everybody. Have a great rest of your day.